Welcome to Introduction to Ocular History Taking. Today we'll talk about some of the most common symptoms that patients complain about when they come to an eye clinic. I'm Dr. Evelyn, and at the end of this session, you'll have a chance to ask your questions. So this is just an outline. Whatever I haven't covered, please do feel free to ask. First, let's talk about the most common complaint, which is blurred vision. Patients may complain that they can't see or that they can't see as well as they used to. So vision is subjective. So you will also need to quantify this later, but that will be covered under examination. So for blurring of vision, you first want to ask them, is it one eye or both eyes? Because certain conditions affect one eye more commonly, and there are some conditions generally systemic which affect both eyes together. So is it unilateral or bilateral? Next, ask them about the location. Is the blurring of vision central, suggesting that it might be related to the optic nerve or to the macula? Or is it peripheral, where it's the periphery when it's the periphery they can't see, then you're thinking more of glaucoma? Or is it related to a specific area, maybe superiotemporal, then you're thinking more of something vascular because that supplies a certain location. So you might have vascular causes like branch retinal artery or vein occlusions, or you could have a retinal detachment, or even non-arteritic ischemic optic neuropathy, because the optic nerve is also supplied by vessels. So if certain vessels are affected and certain vessels are not, then that's why you get a specific distribution. Or you could have generalized. Overall, everything is blur, suggesting that it's a media opacity. So media opacities can include cataract and anything in the vitreous. Example, vitreous hemorrhage. So these will be common things I'll be thinking about. Next, ask for any associations. What are the associations? Is there pain? Because pain suggests that there's something anterior. Usually the retina doesn't feel pain, so something posterior will not cause pain, but anterior segment involvement, such as with the cornea or the conjunctiva, anything in front, usually there are pain receptors there, so you get pain. Ask also about eye redness, because this is a sign of inflammation, which could be due to infection. Whenever you have pain, redness, you also want to ask about any headache, nausea, and vomiting, because pain can also be due to high intraocular pressure. And if there is pain associated with headache, nausea, and vomiting, you're often thinking of acute angle glaucoma. So an acute angle closure attack. Also ask, of course, about the duration, because you want to know whether it's acute, again, tends to be more vascular, versus slowly developing or progressive. So it continues. Then you're thinking if it's about something like cataract or diabetic retinopathy. If it's acute, maybe a retinal detachment, something traumatic. Many things can be acute, and generally the patient will notice it more if it's acute. We're also usually more worried if you come with something acute. It's more likely to be an emergency, such as sudden loss of vision, and you're thinking of a central retinal artery occlusion. If it's chronic, the thing is that it's been happening for a very long time, so we don't feel, although it is still important, but you will not feel as worried because this problem was there yesterday. So you may want to ask, what brought the patient here now? What pushed the decision to come now? Did it get worse? So you want to understand a little bit more about that. Then we also have other complaints, like other symptoms, actually. Glare. So glare tells you something about that. It's usually a cornea problem, or something in the anterior chamber. Because if there are cells, such as in uveitis, you can get a kind of photophobia, which patients may mistake for glare. And then if your cornea has edema, you also can get glare. Or you could have, if you have a cataract, such as a posterior subcapsular cataract, that's also another reason patients tend to have glare. Then if you have foreign body sensation, Again, think of something anterior. Maybe an eyelash got into the eye, because the cornea is the most sensitive, one of the most sensitive parts of the body. So if anything gets in or anything touches the cornea, then you feel a foreign body sensation. So look on the cornea for that, look for a foreign body. Other common complaints, one more here would be, if you want to ask about posterior segment, we usually talk about floaters, flashes, or a visual field defect. These are the three things you must ask for when you're thinking of a retinal detachment, because what happens is that if you have something pulling on the eye, like traction on the retina, it might pull on the vitreous until something tears, like a blood vessel, and then you'll get something like floaters. Or when you see your vitreous, as you age, your vitreous will degenerate and the collagen and the gel will separate, then you get floaters. So this is a risk factor for traction on the retina via a process called posterior vitreous degeneration, and then posterior vitreous detachment actually. Then after that, if anything is pulling on the retina, it can stimulate the retina, so you get flashes. And if it continues pulling and it tears the retina and you get a retinal detachment, that's where you get a visual field defect. So these are all clues to when you're worried about a retinal detachment. Also, in line with this, ask the patient about whether they wear spectacles, because myopia is a risk factor for this. So for your ocular history, in addition to your main complaint, we go on to asking something about the ocular history. So a simple thing to ask any patient would be, do you wear spectacles? So you know, if they do, how high was your power? What prescription were you using? Because you want to know whether they're very short-sighted or very long-sighted, because it's usually associated with a very long or short eyeball. Then you also want to ask them about any trauma. So that's a simple thing, because having a history of trauma, eye trauma, can cause a lot of things in the eye. So these are common questions in the ocular history. Also ask if there's any family history of ocular problems, such any family history of blindness. Sometimes they don't know why, what eye problem they have, but they know there's a family history of blindness, because some things that run in the family are glaucoma and history of retinal detachment. So these things can happen in families. There are other conditions, but these are some common ones that we want to cover. So that's for blurring of vision. Remember to differentiate it from double vision, also known as diplopia. Make sure that the patient is talking about blurred vision rather than double vision, because double vision can be dangerous, especially if you're talking about binocular diplopia. So first you want to find out, is this double vision bilateral or unilateral? Is it present when you close one eye? If it's present only in one eye or in the other eye, then it suggests that it's a problem with that eye only. So you have to look at that eye. But if it's a problem which only occurs when both eyes are open, this is a problem of extraocular muscle imbalance, which can be due to a nerve problem. Because you know that the cranial nerves control the extraocular muscles. So if you suddenly have double vision, and this double vision is present only when both eyes are open, you are concerned about a nerve problem, usually a cranial nerve palsy. And one of the common cranial nerve palsies that we worry about would be, you know that the ones that affect the eye are third, fourth, and sixth. So because these control the eye movements. But if you have a third cranial nerve palsy, a life-threatening cause could be a posterior communicating artery aneurysm compressing the third nerve. So this is life-threatening. While if you have a sixth nerve palsy, you want to look and check whether this is a false localizing sign in high intracranial pressure. So that's why it's important, if the patient comes with binocular double vision of sudden onset, that you need to check their extraocular muscle movements and make sure you exclude these conditions. For the fourth nerve, yes, you can also have rarely something like a tumor or trauma causing it, but more common is the third and sixth nerve. So other things you can ask when you're asking about double vision is it vertical? Again, suggesting This one will help you differentiate which muscle is involved versus horizontal, because you know that the fourth nerve affects the superior oblique muscle. So for that one, you get a kind of vertical diplopia, while you know that the sixth nerve only affects the lateral rectus. So that one tells you if the patient has horizontal double vision, then it's more likely to be a muscle or a nerve that affects muscle that controls the horizontal eye movements. Also ask the patient where the double vision is worse, because where it is worse also tells you that's the muscle that's involved. And is it worse at distance or near? Usually if it's worse at distance, maybe you'll be thinking about a muscle that is useful for divergence like lateral rectus, while for near, a muscle needed for convergence would be the medial rectus. So in line with this, because we are thinking of these things like a PCOM aneurysm or high intracranial pressure, remember to ask for your associations. Example, headache, worst headache ever, suggests a subarachnoid hemorrhage, nausea, vomiting. Next one we talk about is eye pain. We've talked about that a little bit in terms of what are the cardinal symptoms of or signs of inflammation. So usually pain goes together with redness, anything anterior to the ciliary body would generally be able to cause this. Anything posterior wouldn't. So your landmark here is the ciliary body. For example, behind that you have the lens. You know that a cataract doesn't cause pain unless it has caused the complication of high intraocular pressure, which has caused a ciliary body spasm. So only in some conditions you get that, but otherwise from the conch, cornea, anything in the anterior chamber like uveitis, then you get these conditions. Behind it from the lens, vitreous and retina, these are painless. So your cataract is usually painless. Things at the front will be painful. Then if the patient just comes to you and says, I have red eye alone, so it's not associated with pain, then you want to ask about any discharge. Usually it is associated with pain if there is inflammation. So if there's discharge without pain, think of conjunctivitis. This can be allergic if it's itchy, versus it could be infectious. So ask the patient whether they were in contact with anyone else with similar symptoms. For infectious, it can be viral, where it tends to be more watery, versus bacterial, where it tends to be more mucopurulent. If you have discharge and pain, then think of a corneal ulcer. So check, is the vision blurred? It can be an ulcer, but if the vision is not blurred, maybe the ulcer is at the periphery. So this one will have to go into your examination again. Or if you are just having discharge, purely discharge, without any pain, without any redness. So now we have to go for discharge alone. Discharge in a white eye. This is something that we often see in mothers with newborn babies. They'll say that my child's eye is tearing. It's not red, but it just keeps tearing. So things you need to rule out would be congenital nasolacrimal duct obstruction. But other causes of this, perhaps not discharge, but actually tearing, because your patient can't often tell the difference, you need to make sure it's not photophobia or blepharospasm in congenital glaucoma. So that's what we have to check for. But if the eye looks completely fine, it's just a problem of tearing. It's not photophobia or blepharospasm in congenital glaucoma. And it's not because the eyelashes are poking the cornea, such as in epiblepharon. Then we can tell the patient that, give the patient reassurance, give the mom reassurance to tell her that this is due to the fact that the tear drainage pathway hasn't opened yet, and that we can still advise conservative measures if the child is not yet 1 year old. So another common complaint, which we'll talk about and many of you may be experiencing will be dry eye. So what are the symptoms of dry eye? The patients may not know that they have dry eye, but they come to you telling you that they have intermittent blurring of vision. They also have eye discomfort or a foreign body sensation. And all these things are improved by blinking or putting eye drops. And worse, by doing computer work, like they say that, because these are some of the things that you need to focus a lot, or when driving. So these are when they feel the problems most. And generally, these patients may be either older, especially post-menopause, or they could be post-surgery. Example, after a history of any eye surgery. Also, make sure you check whether they can close their eyes, although that part will be under examination, because that could be another reason why you're getting dry eye, like in a seventh nerve palsy. So for dry eye, ask them about, they may complain also of some redness even, if the eye is very dry, and all these things are improved with eye drops or blinking. So that's one clue that tells you that maybe what you have is dry eye. Okay, so to run through, right now we've talked about blurred vision, double vision, some basic ocular history, ask them about spectacles, trauma or family history, eye pain and redness, which tells you it's something more in the anterior segment versus painless things, non-red will be in the posterior segment. Then redness, whether associated with pain, think of an ulcer, or with discharge, think of conjunctivitis. Or if you just have tearing without redness, then think of congenital nasolacrimal duct obstruction, congenital glaucoma, or epiblepharon. And then we also have dry eye. So now, to round up, let's just talk about how you might approach a patient who comes with blurring of vision. Probably the first thing you want to ask would be whether it is one eye or both eyes. So this one here would be one eye or both. Then ask them, is it acute or chronic? Because some basic differentials, if you have slowly progressive painless blurring of vision, actually I would think that the acute also asks about pain, and in chronic it usually wouldn't be painful, because if it had been painful they probably wouldn't have waited so long. So if you have slowly progressive blurred vision, it probably wasn't troubling them, it wasn't causing them any significant discomfort, otherwise they would have come earlier, you wouldn't be suffering pain. So generally, if you divide them, you'll find that the chronic ones are mostly behind from the lens onwards, lens, vitreous, and the retina, while the acute ones can be both, because you could have acute painful and painless, which would be usually maybe either a vascular cause, because if your vessel suddenly gets blocked, you have kind of like a stroke in the eye, then you immediately lose your vision. So you can have vascular causes or retinal causes, like a retinal detachment, while painful things would be something like, again, anterior segment. So you'll be thinking of a corneal ulcer, acute angle closure glaucoma, or anything which you have suddenly have acute high intraocular pressure of any cause, or uveitis. And of course, there's always trauma. It can cause anything like corneal laceration. So trauma can cause anything. It can cause a corneal laceration. It can cause, maybe we'll have to talk about all the consequences of trauma next. So if it's acute, I want to know whether it's painful or painless. If it's painless, I'll be thinking of vascular or retinal causes. Vascular causes will be like a central retinal artery occlusion, a central retinal vein occlusion, even optic neuritis. It can also be vascular. It could be infective, but otherwise it's again something that comes with acute painless loss of vision. And then for retina, Ask them, make sure, remember you asked about floaters, flashes, and visual field effect to look out whether this is a retinal detachment. I mean, as a clue. Then for chronic causes or slowly progressive causes of blurred vision, your most common one might be a cataract. Second, perhaps diabetic retinopathy. So here you'd have to have your whole history of diabetes. How bad was their diabetes? How long had they had diabetes? Because that's another risk factor for diabetic retinopathy, the duration of diabetes, the control of their diabetes, how was their sugar, have they ever had an eye check-up, so you know what was the diagnosis at that time. Are there any micro and macrovascular complications of diabetes? Because if the vessels elsewhere were affected, it's quite likely that the vessels in the retina would also be affected. Other causes could be primary open-angle glaucoma. Again, it causes slowly progressive loss of vision, usually from the periphery. So eventually they end up with tunnel vision and they don't notice it happening because the central vision is spared until the last point. Or you can also have age-related macular degeneration. Under the diabetic retinopathy, you could also have the diabetic maculopathy, because the macula is the one controlling the central vision. So if you just have diabetic retinopathy and it's affecting the periphery, the patient may not notice it. But you have diabetic maculopathy, when the macula is affected, that's when the patient says that they have difficulty with the central vision, like recognizing faces. So here, this one gives you a kind of algorithm for blurred vision. You do want to know at any point, is it one eye or both? Then find out whether it's acute or chronic. If it was slowly developing, think of a cataract or diabetic retinopathy or glaucoma or age-related macular degeneration. If it's acute, then common causes would be a cornea, whether an ulcer or an injury like a laceration. We can put that up here. Uveitis, angle closure glaucoma or high intraocular pressure. And then painless causes would be maybe central retinal artery or vein occlusion, or it could be a branch retinal artery occlusion or branch retinal vein occlusion, or optic neuritis, or any damage to the optic nerve will also be acute. And for retina, look for a retinal detachment. So remember that trauma itself can cause anything from the anterior to the posterior segment, including cranial nerve palsies, because if you hit something, you can injure it. So trauma is one thing that you should never fail to ask. So now let's talk a little bit more on one more separate condition, proptosis. The patient may not be able to tell you that they have proptosis, but they'll say that they notice that their eye is bulging out, or people comment on the fact that their eyes they look like they have a staring gaze. So some of these things may be some of the symptoms. They say that they have a staring gaze. So when you're thinking of proptosis, again, is it unilateral or bilateral? And then the common associations of this would be thyroid eye disease. So make sure you ask about symptoms of hyperthyroidism or hypothyroidism. You also worry about a tumor. So ask about, again, any constitutional symptoms, although these tumors often don't cause constitutional symptoms. Maybe some do and some don't. Some are just localized, but ask them about looking for malignancy anyway. So look for malignancy as a cause of the proptosis. But the most common cause of unilateral or bilateral proptosis will be thyroid. So always rule out thyroid. Other causes might be a carotid cavernous fistula. This one can be associated with trauma, so ask them again about trauma, or it can occur spontaneously, like in patients with hypertension perhaps. So ask about medical illnesses. And the complications of proptosis are high intraocular pressure and exposure keratopathy, and one more, optic nerve compression. So some clues to this would be, ask them, do you have optic nerve compression? So for high intraocular pressure, it's a bit hard for you to ask them unless you ask them about pain. Exposure keratopathy, you'll notice that they have red eye, but ask them about any foreign body sensation, difficulty closing their eyes. And for optic nerve compression, the evidence of this would usually be blurred vision. So same with exposure keratopathy. If your eye is continually exposed, it can dry out until you get a corneal ulcer and a scar, again leading to blurred vision. Now let's go to another complaint, metamorphopsia. This one refers to a change in the size of the images that you see. So the patient might tell you, not the size actually, the best example would be to say that a straight line appears wavy. So that would be metamorphopsia, as opposed to aniseikonia, which would be about the size. So let's say you have different power in each eye and you're wearing glasses. You might find that because of the effect of the glasses, the image from one eye looks bigger than the other. So it's hard for you to combine both the images, and then you call this aniseikonia. So usually it's due to a difference in the refractive error between the eyes. While metamorphopsia, we're talking about one eye itself. Patient maybe says that with my right eye or with my left eye, when I look at a straight line, it appears wavy. So it causes a change in the shape of like a straight line. So the easiest is to ask them to do look at an Amsler grid. Later on you'll be studying what that is, or look at any straight lines like the door frame. Ask them, is any part of it wavy? When you look at straight lines, are they wavy, or is any part of it missing? Then this is metamorphopsia, and it tells you that there is macular pathology. So the problem is in the macula. Okay. So any distortion in the shape of an object that you see is metamorphopsia, and it is most commonly due to a macular problem. So now let's give some examples perhaps. So for examples, let's say we have a patient, number 1, he's complaining of a 5-year history of blurred vision. Then what do you want to ask next? So it's slowly progressive, it's painless. So you know now that you're thinking of something in the posterior segment rather than the anterior segment. He doesn't wear spectacles. He doesn't have a history of trauma. The blurring of vision is the same at distance and near. So you know that it's not because he's presbyopic. He also tells you he can't drive. Somehow he keeps having accidents. Probably if you can't see, then you can't drive. Family history, now you want to ask. He has a family history of glaucoma. So what are your differentials here? Well, without examination, it could still be a cataract. As we said, that's the most common cause. You haven't asked whether he has any medical illnesses, so it could be diabetic retinopathy. We haven't even talked about whether it's unilateral or bilateral. Okay, let's say it's bilateral here. So cataract can be bilateral. Diabetic retinopathy, again, glaucoma can be bilateral also. So pretty much this will be your 3 differentials: cataract, diabetic retinopathy, or basically diabetic maculopathy. If you want to know more, usually it's due to macular edema. The macula is swollen, or glaucoma. And then to narrow it down, you will have to examine him. For the next case, we have a 21-year-old patient with painful blurred vision. So it's always blurred vision in most conditions that we're worrying about. So here it's painful. So when you ask him more, he says that it's acute onset, 3 days. He also has red eye. He doesn't remember any history of trauma. He has some discharge, which is whitish. So what do you do next? Well, you're thinking here of conjunctivitis because of the discharge. Because it's painful, maybe a corneal ulcer may be more likely. Uveitis can also have pain and redness. And then maybe not so much discharge, but actually more of tearing because of photophobia. He could also just have a really dry eye, but usually you may not have discharge in that, so we'll maintain it as conjunctivitis, a corneal ulcer, and uveitis. And one thing, if you're thinking about a corneal ulcer, always ask about contact lens use, because this is a risk factor for corneal ulcers, and the most common organism here is a very dangerous bacteria called Pseudomonas. So it can cause your corneal ulcer to progress very fast. You can even get a corneal perforation, and you'll end up with a permanent scar. Then one more, your nurse comes to you and asks whether to give this patient with diplopia or double vision an early or late appointment. So your question to her is it acute or chronic? And she says it's acute. So you tell her, what else do you ask? You need to know, always remember, is it unilateral or bilateral? So if it's binocular diplopia of acute onset, remember that you have to exclude a cranial nerve palsy. So better see them early, since this can be life-threatening. Now we have one more. This patient comes to you with he's a 60-year-old patient. He has a history of diabetes for 10 years. He's been under follow-up but never had an eye check. He has end-stage renal failure already. He also has ischemic heart disease. He has neuropathy, glove and stocking. So that's all his diabetic stuff. And now he's saying that I have sudden onset of blurred vision in my right eye. So what do you think the cause could be? Sudden onset. Well, I will be wondering whether, number one, if this sudden onset of blurred vision is a generalized one. I'll ask him whether he also saw any blood in the eye. Vitreous hemorrhage would be what I'll be thinking about, because possibly his retinopathy was going on unchecked and nobody knew until the point where he developed a proliferative diabetic retinopathy, and when one of the new vessels bursts, you get a vitreous hemorrhage. You still have to exclude tractional retinal detachment in advanced diabetic eye disease. Again, a complication of his diabetes. Ask about floaters or flashes. Ask him whether it's mostly the center affected. For this one, it wouldn't be acute actually, but maybe subacute, where he noticed it. Maybe on closing the other eye, he noticed that actually this eye is affected. It didn't happen overnight, but he only noticed it now. So that's why he tells you it's acute. Look out for clinically significant macular edema. So all these things are things that happen in diabetic patients. When you are examining a patient with diabetes, consider that the most likely cause of their problems would be the consequence of their diabetes. But they can also have other problems. So other causes of sudden onset of blurred vision in one eye. Remember, we have central retinal artery occlusion, all the vascular problems, or central retinal vein occlusion. This one is for these vascular problems. Hypertension and diabetes, lifestyle diseases are also risk factors. So this is also quite possible. So you have 4 differentials here. Vitreous hemorrhage, advanced diabetic eye disease. Example, if you suddenly got a tractional retinal detachment, you could have clinically significant macular edema, or you could have, which didn't happen suddenly, but you have to include this because the patient may just have noticed it, or he could have a vascular problem like a central retinal artery or vein occlusion. Now, I think for the last one, let's cover just a simple example of a patient coming in, young patient, maybe he's 30 years old, coming in with a history of trauma. What happened is a shuttlecock hit his eye. So what are the things that could have happened in his eye? I guess in this example, there wouldn't be much to ask, except again, there are common symptoms. Blurring of vision, pain, redness. He may have all of these things. And all it tells you is that the eye is affected. But within the eye, you have to move on to your full examination to find out what exactly has happened. And for that's a subject for another lecture. So with that, I thank you. And if you have any questions that we don't address in the discussion, you can email me at evelyn@usm.my.